very good of you. Welcome to another clinical lecture organized by Dr. Sweeta Psychiatric College. I think you have been with us since the beginning of this year, and slowly we are getting off to some exotic topics as well. So today we have an emergency topic, which is the very first in our lecture series: swallowed surprises, emergency department management of foreign body ingestion of children. Which will be done by our consultant physician, Dr. Prasanna Nadarajah. Yes, sir. Over to you to conduct your lecture. Thank you.
Right. So thanks for the kind introduction. My name is Prasanna. I work downstairs in the accident service as a consultant with two other people. And we took this topic because this is pretty common. This is like the third highest presentation that we see day to day in accident service, including your ear, nose, throat, foreign bodies as well. And you see, people sometimes get too afraid and start transferring and do stupid things. So I thought it would be a good topic to talk about. Few things before we start. If you had noticed on the flyer, we just wanted this to be an interactive thing. So if you got your phones, what you can do is you can just scan the QR code and join up. And then you should be able to answer questions without, worried about any judgment or anything. So if you can give it a go. Or otherwise, you can just log into the website on top and just use the number. Okay. You can use the code on the other side as well if you can't see this one. Or what you do is you just join to menti.com and just put the number 7704072. Yeah, I mean, just a quick disclaimer. Yeah. Sorry. Thanks for the email. We are a bit on a tight schedule, and there's a bit of like I said, there's a bit of problems with technology anticipated. So if anything goes wrong, you're just going to go back to the usual traditional PowerPoint lectures, right? Assuming that you guys are in, let's see. And again, when you say foreign body ingestion, there's quite a lot of things to discuss. It's not only ingestion, like when a child takes in the mouth and go into the airway as well. But for this session, we are going to limit to ingestion only. We are not going to go deep into inhalation, right? Any issue, technical issue, we are going to revert back to traditional PowerPoint stuff. We'll see how it goes. Right. So quick question. If you can see on your phone, can you answer who this guy is? You should be able to see the picture on your phone as well. It's 1, 2, okay. This is just to see if it works or not, okay. All right, cool. So correct answer is Captain Jack Sparrow, right? So we are going to use this to sort of answer questions. So let's see how it goes. Again, we're gonna so what we want you to take out of this is to understand the basics, because that's going to decide on your clinical management. Initial management assessment is what you do for category 1 and category 2 patients. Like patient comes in and you rush and do something. So on the basic stuff there, we're not going to go deep into it. We're going to focus on the assessment of the patients, management, and disposition. So the questions are, if you go back to anatomy, physiology, and pathology and all that stuff. First question is, where does the foreign body get stuck once it's ingested? And secondly, what's your average gut motility for a child? And if the object passes esophagus, what usually happens, what the sequelae once it goes into the stomach? And what's the risk of perforation if a child ingests a sharp object? Okay. So usually 80% of the objects ingested pass without any issues, right? The rest of the 20%, so out of that 20%, a further 20 of that usually gets stuck in the esophagus, okay? That's where most of the trouble is. And in children compared to adults, it's about 3/4 of that 20% usually gets stuck in the upper esophagus. Rest of it is in the middle and lower. This is a bit significant because compared to adults, it's higher in children. And if they come pretty early to you and they say they start coughing anything, they can accidentally start aspirating it as well. So there's a bit of a risk there. Once it goes to the stomach, 60% goes to the stomach, and usually they don't progress from there. About 11% gets stuck in pylorus in the bend where you have the pylorus and the duodenum, and about 11% gets stuck in the ileocecal near the appendix, right? But saying that, nearly 80%, I mean, out of all foreign bodies, most of them really pass without any issues. Usually, your patients are about 6 months to 6 years of age. 6 months is where your patient develops palmar grasp and start putting everything in their mouth. And usually 6 years is the average one, but we do get more advanced ages as well. And you have to remember, most of them are witnessed by the caregiver, or the patient would have gone and told the parent. And at times, people don't really realize. So it's like incidental finding X-rays, there's a foreign body, right? And if they have not seen it, you get this different presentation, like unexplained new cough and all that stuff. We'll come to that. Usually in Sri Lanka, it's mostly coins and button batteries. Then you have marbles, pins, and needles as well. You have to remember, for a child, anything is game. Anything that's shiny, anything that's colorful, they will eat it, right? And we can show you pictures of so many funny things as well. And the second question, what's your average gut motility time in a child? There's supposed to be a question in there. I'm sorry. Yeah, supposed to be a question here, but that's fine. So there's no, I mean, for children, I mean, if you remember back to your physiology, in children, there's no perfect studies done, but if you can read in the internet, targeted studies, like when they do video capsule endoscopies and stuff, the usual range is between 15.1 to 39.4 hours. So any foreign body that's ingested should be out by the 5th day. And when you go through case reports of foreign body ingestions, usually reported about 4 days to 5 days. So once it's in the stomach, they usually pass it this stool in about the 5th day. And the extreme is about 2 weeks. So you can only go up to 2 weeks, but all should be about by 5th day usually. Yeah, I'm sorry. Yeah, the question should have come earlier. That's fine. Let's go to the next one. And the other question is, if it has passed the esophagus, dropped into the stomach or below the diaphragm, what's going to happen to this child or the patient, right? So the magic number is 6 centimeters, right? 6 centimeters in length or 2.5 centimeters in diameter. Anything more than that has less chance of passing through the pyloric sphincter, so that will be retained. Anything less than that has a chance of passing. Okay. And even in that scenario, probably 10% of all your gastric bodies, the gastric foreign bodies, may need upper endoscopy retrieval, either because they had not been progressing, or they could be toxic, or could be like expensive stuff, something like that. Like if your child swallows a ring, then you are not really going to wait till it passes on the 5th day. You might want to take it out sooner. Right. Again, see if you can answer this one. So you get a bunch of Sri Lankan coins here, and the magic number is 2.5 centimeter diameter. So which coins are 2.5 centimeters and less? All right. So if you check the diameters, I mean, look, this is, I mean, you can ask a statistician, but whether it's going to be correct or wrong. If you check the central bank, or if you measure it, the old 1 rupee coin is 25.4 millimeters, right? So anything smaller than an old 1 rupee coin is less than 25. So it's your 5 rupee coin as well as a new 1 rupee coin, your 50 cents or whatever. Your larger 2 rupees and 10 rupees will have high chance of getting stuck. Okay. And again, the biggest question, the child ingests a sharp thing, a needle, a pin or an open safety pin, what are the chances of it causing harm after it passes the esophagus? So in esophagus, yes, there's a chance of perforation, but once it goes to the stomach, most of the time they pass without any issues, right? And to understand your management outcomes, how you're going to escalate your management, you have to understand the possible sequelae, right? So out of the whole lecture, you would see that we are more focused on a button battery. The reason being, especially in the esophagus, right? Reason being, you got a charged battery, and if you get like a lithium or alkaline battery, they tend to develop superoxides. They causes alkali burn. And the neck being a small, very limited structure, you can imagine it can just erode through multiple ways, right? So it can damage your esophagus, it can go into the airway, it can cause an AV fistula, which can cause the patient to bleed and die. Even can go into the spine as well. So if you have had patients dying due to foreign bodies, it's most always going to be a button battery here, button battery in the esophagus, right? Stomach and below is pretty safer, but any button battery in the esophagus is emergency. And what about magnets? Usually one magnet is fine, but if you got two magnets or a magnet and a metal foreign body, what's going to happen is they are just going to catch the mucosa, like the gut between them. So that's going to cause pressure necrosis, and you're going to end up with a bowel perforation. So if it's more than one magnet of foreign body, that's going to be risky. And other metallic foreign bodies, let's say, remember the magic number, 6 centimeter in length and 2.5 centimeter diameters. Less than that, they usually pass through without any issues. More than that, then you had to watch and wait and see. The mention differs. There are reports of sharp objects causing intestinal complications, but saying that majority usually pass without any issues. And non-metallic foreign bodies, usually you'll be thinking of food boluses or fish bones. They are usually in your oropharynx. The other stuff is like plastic things that these patients swallow. And there's also this water beads, the superabsorbent polymers, which you'll see later. Right. So initial management and stabilization is what you do before you get your history. So these are patients that, you should rush in into your resource room or whatever. Okay. You don't have time to take history and stuff. Usually they come to you, the patients comes to you in two states, right? So you have the triage category 1 or category 2, or triage cat 1 and cat 2 coming in with the first picture. So you're getting a patient in distress, choking, unable to breathe, and severe desperate distress, which will come in as cat 1 or cat 2. And majority is these innocent looking children, bit upset or bit, looking bit afraid because mom is very upset, but otherwise no symptoms at all. So that's your cat 3, 4, and 5. Okay. So what do you do for cat 1 and 2? Remember, usually or most of the time it's due to an inhalation. So patient had taken it and has gone down to the airway, right? That's what causes most of your choking episodes. And at times, in unwitnessed presentations, the patients sometimes come with intractable seizures. So had been treated with multiple doses of midazolam, whatever, still seizing. And when you plan to intubate, you see these rambutan seeds or, little fruit stuck in the vocal cord causing obstruction, right? So sometimes you do get these seizures as well. And how do we manage them? Those who had attended APLS? Yes? That's pretty tricky if you're working in a children's hospital. I hope you guys know APLS. So the first thing to do is not to panic. And when you get patient with choking aspiration, please go through the APLS pathway, right? The patient can cough, encourage coughing. If they can't cough, right, you go through the other pathway. I'm not going to go deep into that because we won't have enough time. Again, these patients, we have a low threshold for urgent intubation, right? We'll be keeping them under observation. If they are coughing well, we'll just keep them under observation. If they are not, we'll probably go for an early intubation. And in this scenario, we will start pre-oxygenating well with nasal cannulas and stuff. we will probably not put sea pepper water because it's still going to push the foreign body further down, right? So we'll plan for an early intubation, and we are not going to discuss aspiration much more. We are going to focus on ingestion here. Right, stable or minimal symptoms. Now, these are the patients you're going to look at and you think they are okay, CAT 3, 4, 5, and you can sit down and take history. Could be with minimal symptoms, or could have something like an unexplained new cough, could have choking or drooling, or refusal to eat, which the mom has noticed, right, or difficulty in swallowing. And still again, remember the button batteries. The patient can still be asymptomatic with an esophageal button battery, okay? So that doesn't mean you can slow down, you still have to act very fast. So if the mom says it's a button battery or whatever, even if the patient is asymptomatic, you have to act very fast. And in these patients, still it could be a possibility of an aspiration, but could have gone into the bronchus, so they may not have enough symptoms. Again, could be esophageal foreign body, so button bat is problematic. Even other your needles and stuff could cause perforation. So still there's possibilities there, and you have to think of an early action here. Right, so your patient is stable, little minimal symptoms. Now you have time to go with a history and examination, right? So usually in history, if the patient says, let's say 6-year-old says, "Mom, I had gone and swallowed this," or if the mom had seen it, it's pretty sufficient to say it's a foreign body ingestion. And at times they don't have symptoms; they are looking very nice, quiet, calm, looking cute without any issues. For further management, the history that you need to take is what was the time of ingestion and what was the product that I had taken. And then you need to ask whether this is a high-risk foreign body and if the patient is going to be a high-risk patient, right? Because low risk means you can consider expectant management. High risk means you have to escalate it appropriately. So what are high-risk foreign bodies? So always remember the button batteries in the esophagus, right? That's high risk. A magnet with another magnet or another metal foreign body, and sometimes you do get magnets and a button battery as well, which is much more dangerous. Any sharp objects in the esophagus. Now, if they go into the stomach, that's fine, but still in the esophagus, it's going to be a high risk foreign body. Anything that is toxic, so lead-based things, or if the patient had chewed the usual 3A batteries chewed and swallowed, those are going to be toxic, so those are a bit high risk. Any large objects more than 6 centimeters of diameter, 2.5 centimeters, yes, obviously. Any expandable foreign bodies, like your water beads, which expands about 50 to 100% of your usual volume after absorbing water, that might cause obstruction. And if you have multiple component toys which break down the smaller ones, also going to be high risk as well. And how about your high risk patients? So if there's any pre-existing GI abnormalities, any strictures and stuff, any past surgery and colostomies, you'll be worried about them. Any neuromuscular diseases in the patient, then you have to worry about them. And again, as in pediatrics, look at the social history because that changes your management. If you think this patient lives far away in a place that, let's say in Batticlo, far away, can't come in the night because of elephant-infested jungle, then you may want to consider keeping them. If they live nearby, the patients are reasonable, and you think the patient would bring them back to you if anything changes, you can consider letting them go. So explore that in the social history and see if there's any risk of any psychiatric issues as well, because if there's going to be frequent ingestions, then you may have to refer them to the psychiatrist as well. And if you read the literature, they have mentioned eosinophilic esophagitis, which is a bit common in the Western countries, but as far as I could find in our literature, it's a bit of an adult thing and not very common. But if you know this patient has any esophageal inflammatory conditions, then consider them as a high-risk patient, but we usually don't get them in our practice usually, right? And when you do the examination, most of your CAT 3, 4, 5 patients, the vitals are pretty normal to begin with. You may not even find anything, right? But remember, with button batteries, with your complication, the vitals may start changing. Okay, so always be on the lookout for that. And any patient with symptoms like choking or drooling, look for airway compromise, look for signs of respiratory distress, and look for any signs of bowel perforation as well. Okay, so do a good abdominal examination as well. And when you come to diagnose, there are few options. The best one available to us is the X-ray. Okay, this is one of my favorite X-rays because I hope you can see. I hope you can see a dinosaur in there. It's a plastic dinosaur in there. You can consider CT if there are any complications, right? If there's an AV fistula or any perforation, then consider CT. Otherwise, you don't need to go for a CT. Bit of novel things that we used to do. If this is a super magnet, you can try to use a compass, but there's always an X-ray. So yeah. And if you got a metal detector, you can use for a metal detector for non-metal and like non-button battery stuff. Again, we've got X-rays. So X-ray should be good enough for all of us. Okay. If you feel adventurous, you can use the other two. And when you consider your imaging, remember the Alara principle as low as reasonably required, right? So we don't want to do multiple X-rays if it's not indicated. So remember our priorities: button batteries, magnets, multiple magnets. We will be more, or patient with symptoms, we are more willing to do X-rays. Plastic foreign bodies, which are small and stuff, you may not even consider doing them. Okay. Think if your X-ray is going to change the management downstream. So one X-ray would be fine, and if you think this patient is going to have a uncomplicated progress, you may try to avoid the X-ray as well. See, think whether this is going to be a radio lucent or radio opaque one. If it's radio lucent, then unless you're worried about co-ingestion stuff, no point in doing it. And if there's any evidence of complications or symptoms suggesting complications, please do it. Otherwise, you can think of not doing it. Do we need to do any routine bloods for these patients? Considering, let's say, considering lead-based injection stuff, technically we don't need to. I mean, it's not going to change your management, so you don't need to do any bloods at all unless you are expecting to do a GA and you need, basic management. You can do it, but otherwise you don't need to do any bloods, especially for most of the patients you're going to send home. Right now, this is something that you can consider. You may, the term is may, you may not do an X-ray if the patient has each and everything of this. The patient's asymptomatic, a completely normal examination, no known gastrointestinal anomalies, and you keep them in the ED for 2 to 3 hours, and the patient looks perfectly fine, runs around and interacts well, and eats and drinks well, tolerate their food and drink, and I hope you can see the last 4, right? That's also important. Again, the magic number, 6 centimeters and 2.5 centimeters. If it's less than that, it's not a button battery. It's not a it's like not a multiple magnet or magnet plus foreign body, non-expandable and non-toxic. You can consider not doing an X-ray. Okay, you can just do one X-ray and then forget about it. But if the patient has been symptomatic, if it's a button battery or 2 or 3 magnets, or if you're unsure, please go for it. Even then, try to get an X-ray. I mean, with children it's easier. Try to get the whole, neck, chest, and the abdomen. Sometimes things have been missed, or things have been stuck in the upper oropharynx and which have not been caught in the X-ray. So just be mindful of that as well. Always do it for a suspected button battery. Always do it for magnets. If you don't know the object, do it. If the patient is unwell, do your X-rays. And again, if the patient has complications, consider doing a CT in these patients, right? Right. And when you do the X-rays, what are we looking for? So I thought the important things is there are 3 things that you're looking for in your X-rays. One is whether this foreign body, the suspected foreign body, is in the airway or is it going to be the esophagus. Secondly, whether this child has ingested a coin or is it a magnet, coin or is it a button battery. And thirdly, if it's a magnet, you're going to look for a single or multiple magnets. Okay. So how do you check for airway versus esophagus? So the classical teaching is, you can see the picture on the top. If the coin is or the whatever is on in the trachea, it's going to appear like a line, right? And if it goes in the esophagus, it's going to look like a round. That's the classical teaching, but saying that there have been studies which have found even the the sagittal ones, the lined ones in esophagus as well, right? So it's a bit tricky, but I would say the best way to handle these things is if you see a foreign body above the diaphragm, always do a lateral as well, right? And remember the people who came a bit later, we discussed about this gut transit time. So usually, for in children with studies, they say once the object falls down from the esophagus in the stomach, takes about 2 hours to pass into the small bowel, 5 hours to pass from small bowel in the large bowel. So if let's say this ingestion happens in the morning and this patient comes late and it's still in the esophagus or up, above the diaphragm, just get 2 x-rays. The other question is whether this patient has swallowed a button battery or a coin. All right. So if you remember your button batteries, there's a positive and a negative side. So the positive is the large, smoother side, and the negative is the smaller one. And you can imagine this looks like 2 rounds in there. So depending on the view that you get, you may see what you call a halo or a double ring sign. Okay. I hope you can see it much well here. Here you can see the double ring sign here. All right. So it's going to be a button battery. This one, you don't see any halo double ring. So this was a coin. That's a magnet. Okay. That's the other one. This one. Magnet or a coin? Sorry, coin or a button battery? Button battery, yeah. All right, so because remember, if it's button battery, the management completely changes, all right? And when you think of magnets, now you have to remember, now you have super magnets like rare earth material magnets, which are very powerful, advertised as children's toys, which is available to most of the children. You can even buy it in websites around in Colombo as well. Very powerful. And they are so good. Sometimes you see one single object on the X-ray, but it's actually 2 of them stuck together very hard, like very fast, right? So always get the parent. Okay. Always get the parent to, yes, sir. Always get the parent or the bystander to bring a spare magnet to see and compare with the X-ray as well, in case you don't want to miss 2 magnets. Right, and when we come to management, usually we go for general and specific management. And the specific management changes for these 4. So button batteries will be different, magnets are different than other metallic foreign bodies and non-metallic foreign bodies. So usually general management, now remember, even for any poisoning or any ingestion, we don't advocate for vomiting or like inducing vomiting anymore, because the risk is you're gonna cause aspiration. So just let it be in the GI tract, don't cause vomiting at all. Now, giving laxatives and cathartics is a bit of an interesting topic. Okay, if you read the topics and if you read the articles, especially in the practice in the Western countries, laxatives are not a proven benefit, and polyethylene glycol they think may actually cause harm because may cause hydrolysis. And in general management, if you think this patient has, let's say, cough 10, it's now gone into aspiration, or if you think it's an airway compromise, please, take them to the room and start doing the emergency management. But we're going to go deep into that. And again, remember, sometimes people tend to, especially smaller kids, you tend to hold them upside down and, whack them on the back and all that stuff. Please don't do that. Just go according to the APLS algorithm. Do not try to do these upside down things, because the patient falls down, hits the head and stuff, then you're going to be in a different type of problem, okay? And when it comes to specific management, again, like I told in the beginning, the important thing is the button battery. If it's still in the esophagus in your x-rays, you need to get it out as soon as possible, right? If you're on a center with endoscopic possibility of getting it down endoscopically, call the necessary people, get the theater arranged. You don't need to wait for fasting, send them out there. If you're in your GP practice, or if you're in let's say, a peripheral hospital, again, call the necessary team, get them ready, and send the patient. As sort of like a first aid measure, you can give honey. So honey usually give more than 1 year of age because of the risk of botulism. You can give honey about 10 ml every 10 minutes up to 6 doses. So the honey coats the battery inside the esophagus and prevents the contact with the esophageal wall, as well as prevents the necrotic damage. Okay. Saying that, you don't get honey easily available, but jam had been shown equally efficient as well, and it's available in your patient's canteen. So just get jam, get the patient to eat, take the jam every 10 minutes while waiting for the OT. Don't worry about fasting state, because this is emergency. They have to go and take it out. So you can give your jam or honey or whatever, but remember, with honey, more than 1 year. And if you read around, and especially sometimes people describe this Foley technique, like that they put the Foley catheter down, inflate them, take it out. Looks impressive, but if you got endoscopy, please go for endoscopy, right? Don't try Foley, because you don't know whether they're going to hurt the patient or not. The second reason we advocate for endoscopy is the mucosal damage may not be apparent, right? So if you take it with, so if you do an endoscopy, you can actually see the mucosal damage. Yeah, this is the trouble with technology. So if you do an endoscopy, you can actually see the extent of the mucosal damage, okay? As well as you can sort of do a washout with saline or acetic acid, which you can't do with your Foley technique and stuff, right? So try to go for an endoscopy as much as you can. If the battery had fallen down in the stomach, but patient still symptomatic, you need to get them admitted to take it out, all right? You may need to do it urgently within 2 hours, but within the next 24 hours, you may need to take it out. The patient's asymptomatic, with the button bat in the stomach, or let's say in the small intestine, you can consider sending them home, but you may have to get the relevant specialists involved to have a plan to get this done. So you can send them home, yes, but don't do it by yourself. Escalate to the appropriate consultant, get the plan, sort them out, and the plans change according to whoever you're calling to. So just make sure that happens, and you can think of sending them, or you can keep them if the people want to keep them in. But these people can be sent home with appropriate discharge plans, not just like, simply, but you have to have a good discharge plan. And if it's beyond stomach, usually the button battery passes without any issues. Now, magnets. If it's just one magnet, you can send them home, right, with the discharge plan. If it's one magnet with further another metal foreign body, then it's going to cause trouble. If it's 2 magnets or button bat, is going to cause trouble. So if it's more than one magnet for the metallic foreign body, please admit them for surgical intervention. So they will decide whether they are going to watch and wait. I mean, they should not watch and wait. They'll try to take it out. If it's passed into the small bowel, they will try to take it to the scope. If it's passed more than the scope, then they will think whether surgical or not, depending on the patient. So it's going to be a surgical management rather than an ED management. All right, and these are your super magnets, and you can see It's being advertised as children's toys. Really powerful and easily available. And they stick together like nothing. So make sure you see only one in the X-ray. If you see more than two, you have to be a bit more careful. And these patients need to be under close follow-up. Okay. Other metallic foreign bodies, look, once they've fallen down to the stomach or below the diaphragm, they usually pass without any issues. Remember the 6 centimeters or 2.5 centimeter diameter. If it's more than that, then there's chance this will not progress. If it's less than that, there's a good chance this will just go without any issues. You don't need to plan for serial X-rays unless it's something like a esophageal button battery magnet or patient has been symptomatic. But if the patient is completely asymptomatic and it's a low risk foreign body, you can just do one X-ray in the beginning and an X-ray after 10 to 14 days. All right. And if there's any esophageal foreign body, it is still persisting. So remember, it's usually passes on stomach very quick, but let's say a patient came to you after 4 hours, 6 hours, still in the esophagus, you may consider getting them admitted for endoscopy. And non-metallic foreign bodies, remember the high risk and low risk for non-metallic ones usually pass without any issues. Again, remember the sizes. This more than 6 centimeters or 2 centimeters, you can consider admitting them for any further observation or management. The other thing that, I don't know if you had encountered this, but it's pretty common in Sri Lanka as well. Something called water beads, like super absorbent polymers, not your silica gel, but these are actually used for watering plants and all that stuff, very common. And if you see the picture, you would understand why this is very, very interesting for a kid. Little colorful things which a kid is like to, eat. Looks like candy. And if you see the second picture, each ball comes up to that level, right? And I don't think you can read the third one, but that's the marketing slogan. It's actually being marketed for kids to play around like a sensory toy, right? And you can imagine little kid with sensory issues. With this, they're actually going to put it in their mouth. All right. They are a bit of a tricky problem because they are smaller to begin with. They're radiolucent. And unless somebody has seen it being eaten, you will have trouble in deciding what to do with these patients, right? So if the parents come and say, the child was playing with it, I got something out of the mouth, I'm not sure whether they had ingested or not. Now you are in a bit of a trouble because you don't know how to proceed here. You don't know whether they has actually eaten or not. And X-rays, unless you've got large number of these balls, you will not be able to see it. Or unless these causes intestinal obstruction, you can't actually see them in the X-ray. So what are you going to do now? Are you going to keep them admitted or are you going to send them home and get them back? So the first one shows an X-ray. Well, you can't see anything in there. The third one actually shows, now this actual stomach, and this has actually, got stuck with all the food materials and causes intestinal, obstruction in the mid-stomach, right? But something that you can consider is doing a ultrasound scan. And you should be able to see it in the stomach like balls here, right? Again, not my personal experience, but this is something he suggested. And if you read the reference as well, it's from experimental emergency medicine, right? But this is better than doing nothing at all. So something that you can consider doing a ultrasound scan to see this. Again, do not give laxatives. Do not do whole bowel irrigation, because with your polyethylene glycol and stuff, they will expand much larger than your usual water. So if you let it be, they'll be smaller. If you start whole bowel irrigation and laxatives, it's going to expand much further. You will cause more trouble. So don't give laxatives and stuff. And look, if you need any help, if you need any advice, if you're an LRH or if you're in a tertiary center, you can either call us or call the accident service, call the surgical team, or the other good thing is call the poisons hotline, right? So just call the poisons hotline, tell them about button battery, tell them magnet, they will guide you. If you are in an unlucky place without even phone connection, just have the poisons handbook with the recent one is bit up to date with the details, right? And in an emergency department, we talk of disposition. Now, Are we going to send them home? Are we going to get them admitted to the hospital? Or are we going to transfer them? Usually the easier one is to admit because we are just passing on the responsibility to a different team, right? The difficult one is sending home. But for the patients, especially in pediatrics, where you want the patient, the children to be at home, you better consider sending home as much as possible. Right. So usually, again, now each patient is different, but so it's your rational clinical decision. But usually, if there's a reliable history, so there has been a witness, the history is reliable, and the foreign body is a low risk one. It's not a button battery, or the button battery is known to be, in the stomach or passed on. Patient looks completely well, runs around, playing well, eats and drinks, tolerate, keep the food and water in. No respiratory distress. You can consider sending them home with appropriate discharge instructions, right? Also, like I said, please consider the social circumstances, the ability to come back to your ED if there's any emergencies, as well as if you need to escalate to any psychiatric care as well. And people tend to, like, this is especially with your experience, people tend to worry about sharp things or, clear complications. Please remember, you go through the materials available, like the journals available or case reports available. Most of the times, sharp needles, large needles have passed without any issues at all. And then you read case reports, you have this little bread tags, plastic bread tags. The tags they put on the bread cover, those are caused like obstructions. So it's a bit difficult for you to predict which is going to cause which, but that doesn't mean you have to keep all of them admitted, or you're going to send them all home. So you had to decide on the previous factors to decide whether this patient will come back to you or whether it's safer to keep them in the ward as well, right? So do your assessment and make a rational decision, but most of the time, if they fulfill the previous criteria, you can consider sending them home and getting them back for reassessment. And those of you worried about complications, if you take a bit of time, 5 to 10 minutes, and talk with the parents and give a good discharge advice or a return advice, usually that helps trouble, right? If you give them a proper advice and say, it's somewhere, let's say somewhere in a small bowel, so unless it's going to cause any issues, you can stay at home, it's going to be passed without any issues, and we'll get you back in, let's say, 10 days or 4 days for repeat x-ray, or you don't, if it comes out, you don't need to do it, you don't need to come back at all. But any issue with, let's say, severe abdominal pain, vomiting, melena, whatever, come back and you explain that, explore their concerns. Usually that's enough, right? They will not start going to different hospitals or, go to somewhere else. They manage pretty easy. So take that extra time to give this proper discharge advice if you are going to send them home. And usually we tell them to look for any breathing issues, any abdominal pain, any fever, any vomiting, unable to eat or to, drink any food, and also any melena or hematemesis, right? We'll come to the melena hematemesis a bit later. And when will you, so if you're going to send them home, when will you plan a repeat x-ray? Are you going to get them on the next day, or are you going to get them on, let's say, 2 weeks' time? So usually, when you say high-risk patient, now this is where the button battery has gone down to the stomach and below, less than 6 years of age, and battery more than 15 millimeters. You can get them back in 4 days' time. If they are asymptomatic, you can get them back in 4 days' time and do a repeat x-ray, okay? And if you read a bit of the UK guidelines, sometimes they say to go ahead and do an endoscopy, because what they advise is we do an endoscopy. It's not to take the bacteria, but the purpose is to just to go and see the mucosa to see if there's any delayed reactions or necrosis or anything like that. But this is being influenced by a bit of a what do you say? Bit of a tragic incident where the complication has happened few weeks after the button battery had been taken out, right? So when these things happen, the people in those countries get, write to the prime ministers and do all sort of stuff. So this gets escalated, but it's a rare thing. But now some of the centers may advocate let's do an upper G endoscopy just to see the mucosa or not, right? But here you can discuss with us or research and plan something. If it's a low risk patients, so more than 6 years, less than 15 millimeters, smaller button batteries, ask them to come back in 10-14 days, right? If they see the button battery being passed out, they don't need to come at all, right? They can just stay at home. If they did not see it come out, they can come and get a repeat X-ray done. And if there's other non-metallic foreign bodies, don't bother doing another X-ray. But give a good discharge advice. If there's an obstruction or symptoms of obstruction, you need to come back. And then there's this question of, therapeutic X-rays. It's not for the patient, but it's for the parents as well as for the doctor. So you think this patient may not need an X-ray, but you may have to do it because the parents are anxious or the doctor is anxious. Again, think of ALARA and all that, and think of the patient and the situation. Now, if you think this mother or the parents are very anxious or a bit far away, let's say they live far away, they can't come back to you, you can actually go for these X-rays, right? But think of each scenario on its own. But if you think this is going to help you down, so if you think this is going to calm down the parent, or this makes you calm down, consider doing it. Again, the other question is, would you advise tool inspection for the parents? There should be a question. All right, there's the question there. All right. For the people who are not here, dear. For the people who are not here, just go to menti.com. I'm sorry, I don't have the code. Oh yeah. You can just join through the code, or just go to menti.com, just use the code. I just want to see how many of you would prefer to advise stool inspection. All right, I think the overwhelming majority is for stool inspection. Okay. All right, that's a good thing. All right, let's come to that. Again, differing opinions on whom you ask. All right. If you work in a Western center like Australia, UK, stool inspection is not advised. Their rationale is when they follow patients with X-rays, about 50 to 60% are never seen again. So the mom and dad have not, or the caregiver has not seen the foreign body being passed in the stool, and the repeat X-ray also they couldn't see the foreign body, right? So those places, they do not advise for stool inspection. Now, it's pretty easy when you got a 6-month-old, you can do a stool inspection. But imagine it's a 12-year-old boy, and ask your stool inspection for 10 days. So yeah, you treat the patient in front of you. So I don't want to give a blanket advice, but if this patient has had any issues or symptoms to begin with, let's say had symptoms in the beginning but had been completely all right when you saw him, and if you think patient can go home, but let's say like a sharp needle or whatever, and then you can instruct the parents to say, just look for it. If you don't see it, come. If you see it, don't worry about it. You don't need to come back. If you don't see it, just come back in 4 days or 10 days for a repeat X-ray. Okay. So it depends on your comfort level. I usually don't tell them to do it because you can either catch them after when you get them done for a review. Okay. But saying that, sometimes there are parents who actually want to do stool inspection. So either you can take your time to explain all this stuff, or you can, make them feel better and say, all right, for a smaller kid, you can say, just look for it, right? But ideally, you don't need to. Yeah, I'm being very political about it. Yeah, but I wouldn't. Again, another important thing, again with the button batteries, this patient had been seen in the accident service or in the surgical ward about a week ago, 2 weeks ago, had a button battery, had a removal. Coming back to you with symptoms of, let's say, esophageal perforation or hematemesomelena, there's a possibility there has been a delayed complication, right? So please keep in mind with button batteries in esophagus, if there has been a bit of a delay, there could be delayed reactions as well. This is the reason they advocate to do an upper GI endoscopy, because you can actually see if there's any damage there. So you do Foley and stuff. Yes, the button battery comes out, but you may not see any damage. And again, you may sometimes cause it to fall back into the trachea. So always go for an upper GI endoscopy as much as you can. And transferring for further care depends on where you are, depends on your hospital capacities as well as your comfort level. If you think this is reasonable, so reasonable parents, low risk foreign bodies, you can send them home. Or if you think there's some issue, let's say social issue, whatever, you can consider transfer, right? Actual indications like an esophageal esophageal button battery, please do transfer that. And if you're in a peripheral hospital or if you're in a GP practice, we are sending the patient here, especially for a button battery ingestion, please try to call us and inform beforehand, so we can get things ready here, right? So we don't want this patient to travel an hour from, I don't know, Negampur to here, an hour from there to here, and then for us to spend another half an hour, 1 hour to sort the theater out, okay? So have the habit of calling the unit ahead. The other thing is, if you're going to send them to a different area, try to have a sample foreign body. So if they had ingested a magnet, try to get the parents to bring that, another equivalent sample magnet. So those on the receiving side can compare that, because with the distance, you may not be able to get it easily, right? So that would be much more helpful as well. And when would you consider admitting to ward, theater, and ICU? That's what we've been discussing so far. So your high-risk foreign bodies, button batteries in esophagus or magnets, you'll consider admitting. Theater for your urgent endoscopies. ICUs, if you got a patient with airway inhalation or the airway compromise, if you had to intubate, you had to go there. Any questions? You should be able to ask from there, but any questions? All right. Look, if you got any questions, feel free to call the accident service, or just feel free to call the Poison Center, whatever is fine. Again, so we had looked at a few things. We discussed the basic sciences so we can understand why we are doing certain things. We had a quick look at the initial management and stabilization, the resource room management, but didn't go really deep into that. But what I really want to focus on is the assessment management as well as the disposition. And we looked at, especially the button batteries and magnets, we looked at x-rays, what information you may get from them and how they can help you, as well as when you do consider sending them home with a plan, or when you consider admitting them, okay? Any further questions, you can feel free to ask later on.